Thank you, Dr. Tempty, and good morning. You may be familiar by this point with the ongoing update of our tome, the General Recommendations on Immunization, Storage, and Handling of Immunobiologics. Today we're going to give you a brief update on where we're at and go over one of the current sections that we're working on. Let's see. There we go. As you recall, the general recommendations are published in an MMWR hard copy every 3 to 5 years, and these recommendations address a broad range of clinical practice issues that are relevant to good vaccination policy, clinical vaccination policy for multiple vaccines. They're specific topics that are not pertinent to any one vaccines, but to vaccine and immunization practice in general. This is the current issue, and these are the topics that are covered in the general recommendations, and today we'll be updating you on the revisions that we proposed for the storage and handling of immunobiologics. The next meeting will provide updates on vaccination programs and vaccine information sources, and we may be able to complete our proposed revisions at that time. But I do encourage the ACIP members, the liaisons, and others to please read the documents, look at the proposed revisions, and give us your feedback. We very much appreciate hearing from you. I also want to call your attention to a recent publication that Lori Rubin led for the Infectious Disease Society of America, which are there in their guidelines around the vaccination of immunocompromised hosts. And this topic is also addressed in the general recommendations, but the IDSA guidelines go into a lot more detail, and they provide guidance for clinicians based on a variety of levels of evidence, from high quality down to expert opinion, on various areas, some of which are not addressed by ACIP, and we have some conflicting recommendations there. So it'd be very helpful if you have the opportunity to take a look at the IDSA practice guidelines, so that when we discuss this at the next meeting, if you've got concerns, you can make us aware of those. At this point, I'm going to turn it over to Dr. Kroger. I just want to take a minute to thank Andrew again for all his hard work in revising these guidelines and leading our work group through these processes, and to Doug Kempis, Al Colt, and Cynthia Pellegrini, my ACIP colleagues, and to all the liaisons. We very much appreciate your careful reading and review of these guidelines and your valuable input. It's been very, very helpful.
Okay. Thank you very much, Dr. Duchin, and thank you to the ACIP for allowing the General Recs Work Group to present proposed changes to the storage and handling section of the General Recommendations. So this is an outline of the areas covered in the 2011 General Recommendations document. It's brief. It goes into storage temperatures, the ranges that are appropriate for various vaccines, storage units, proper temperature monitoring practices, the response to an out-of-range temperature reading, and then there's an extensive discussion of expiration dates and windows and multi-dose vials. That's the 2011 document. I want to point out that since the General Recommendations was published in 2011, the CDC's Storage and Handling Toolkit, which is posted on CDC's website, has been extensively revised. Now, this tool contains best practices information for both public and private providers, and really contains very, very precise, exhaustive detail on the following topics, which I show as strikeout on this slide. So storage units, temperature monitoring, expiration dates and windows, and multi-dose vials. There is an extensive discussion in much detail in the storage and handling toolkit, and I show you an image of the first page of the toolkit and the website where it can be found. You will note in the drafts that the ACIP members have drafts of the general recommendations chapter, they will also see extensive strikeout because the General Recs work group really feels like these topics are adequately covered in the toolkit and really don't need to be in the ACIP recommendations. It's covered in two places. I will quickly provide some background as to what's in the toolkit. In the general recs, I will talk about the major topics covered in the storage and handling toolkit, just by way of saying that these are best practices. And they break down to equipment considerations for storage units and thermometers, maintaining the cold chain, routine storage and handling practices, inventory management, emergency procedures for protecting vaccine inventories. Basically, a bulleted line list in the general recommendations with a reference to the website that I showed you on the last slide. Now, just to go into a bit more detail, what's in these sections? Just by way of some examples, there are specific recommendations for the type of storage unit under equipment considerations. Of course, we know that standalone or single refrigerators, single freezers are now preferred over combination units. There is detail about the types of thermometers you should use with their temperature probes encased in a glycol buffer. There is a discussion in the toolkit or a listing of the required temperatures for both frozen and inactivated vaccines. So that's in the toolkit. There are discussions of routine storage and handling practices, the positioning of the vaccine, the labeling of trays and containers, a discussion of inventory management, how you use and interpret the expiration dates that are listed on the vials, and lastly, emergency procedures for protecting vaccine inventories, specifically how you transport vaccines to off-site facilities, the tools you need to use to maintain the required temperatures. A lot of discussion, and actually there's even more than this. There's a discussion of vaccine personnel staffing, a discussion of the actual handling of the vaccine, which is in the storage and handling toolkit. And as you know, the General Recs has its own administration section, which also discusses some handling of vaccine issues. So because it's in there, we really felt that we could delete this information from the general recs, and so you can see that those corresponding subheaders have been deleted from the general recs draft that you have. Storage and handling toolkit is CDC cleared. It represents best practices, as I mentioned, for both public and private. It's harmonized with the Vaccines for Children regulations, which are described in the VFC operations manual. So what are we going to retain in the ACIP general recommendations? Well, we want to keep, even though this is also in the toolkit, we want to keep the table of temperature ranges. Similar temperature cutoffs are published in the storage and handling toolkit, as I mentioned, also in the textbook vaccines. What's unique in the general recommendations is there is a description of the types of vaccines, the categories that correspond to the specific temperatures you should use. We break down vaccines with the following labels: non-lyophilized aluminum-adjuvanted vaccines, non-lyophilized non-aluminum-adjuvanted vaccines, lyophilized non-varicella vaccines, varicella-containing vaccines, and non-injectable vaccines. And that table is on page 5 of your draft. And when I talk about the draft, I'm referring specifically to the draft that has all of the marked changes on it. So it's page 5 is that an example of that table. I'll show you a slide in a bit. Now, we're going to continue using these labels. We decided to add some language to the general recommendations about these categories. Of course, for the aluminum-adjuvanted vaccines, there is a described mechanism whereby vaccines lose potency if they contain these adjuvants and are exposed to freezing temperatures involving the agglomeration of particulate matter in the vaccine. The description is less well described for non-lyophilized vaccines that do not contain aluminum, but the possibility of losing potency has not been ruled out if these vaccines are frozen. So we do make similar recommendations for the storage of these vaccines. And by the way, the refrigeration temperature is 35 through 46 degrees Fahrenheit, 2 through 8 degrees Celsius for these vaccines, the non-lyophilized vaccines. For vaccines that are lyophilized but do not contain varicella vaccine, they don't need to be frozen. Most of them can be frozen. One exception to that is the lyophilized Inhibrix pellet, which really should not be stored below 35 degrees Fahrenheit. Varicella, the fourth bullet, varicella-containing vaccines, these should be kept frozen, and frozen means minus 58 degrees Fahrenheit through 5 degrees Fahrenheit. Otherwise, the vaccine virus will degrade. For the non-injectable vaccines, there's not really a clear mechanism that applies to all in that category. It's generally standard practice, standard that they're not recommended to be frozen, not to be stored below 35 degrees Fahrenheit. There are some injectable vaccines that we know that the dose can be counted if they do happen to be frozen and then found to be administered. The live attenuated influenza virus was an exception to that. So that's in there still, a description of the types of vaccines. Response to out-of-range temperature reading. This is a section that is not specifically covered in the toolkit, and so we do want to make sure that we maintain this in the general recommendations. So there's some duplication of having a plan ahead of time that is in the toolkit. Practices such as marking the vaccine do not use, seeing if the temperature deviation has a solution, a resolvable solution such as the door left open or was the storage unit unplugged. So there is some of that information that's still in there. Moving the vaccine to an alternate site. One of the important issues if vaccine is found to be stored out of range is to contact the state or local health department or the manufacturer to determine if the vaccine is viable. This is not new language. This was in the 2011 general recommendations. We are going to keep that language. If the doses have already been administered and then found to have been kept out of temperature, we do make a specific statement to contact the state and local health department. So make sure that at a minimum, that entity is contacted, state and local health, public health. And so some of the language that we are going to have in this section, I've replicated on this slide. As a general rule, vaccines that have been stored at inappropriate temperatures should not be administered unless public health authorities or the manufacturer determine it is safe to do so. On page 3 of your draft, line 28, that's positioned in a section where we just talk about discovery of vaccine in the unit kept out of range. Then we have the sentence, if such vaccines have already been administered, vaccine exposed to inappropriate temperatures that is inadvertently administered should generally be repeated. Clinicians should consult promptly with state or local health departments in these situations. Consultation with the CDC is available when necessary. And that's page 3, line 31 of the document. The language has been tweaked a little bit. I can tell you that, again, the standard is that inadvertent vaccine administered should generally be repeated. If CDC is first contact from a provider, and we're talking about hundreds of doses having been administered, the state and local health departments, public health, will be contacted in that situation as well. Just a bit more on the table of storage temperatures at the end of the document. We've added Inhibrix to the table. we have added the minimum temperature for all varicella-containing vaccines, which is negative 58 degrees Fahrenheit, or the equivalent negative 50 degrees Celsius. This is a change that's already in the toolkit, and it's a change many of you are familiar with. Probably is not a big deal. Most storage units cannot even reach temperatures this low. We have to put it in there, and it's very, very important because it involves issues of transport that are not going to be covered in the general recs, but are in the storage and handling toolkit. Transport on dry ice can cause variations in temperature that could reach as low as negative 58 degrees Fahrenheit. Hence, we no longer recommend dry ice for transport. The idea being that also, temperatures this low can be damaging because they might affect sterility of the vaccine itself through increased gas permeability of the rubber vial. And so that's one of the issues that we have decided to put some, as you'll see, there is some wording in your draft on this. Also, with the table of storage temperatures, we've removed entirely one of the columns, a comments column. It used to contain some information on light sensitivity, what data there is on the degree of thermostability. That's in the FDA product information. We felt we could get rid of this information as long as we refer to the FDA as well as and package inserts. So we've removed that table completely because really there is a lot of detailed information now, and it can easily be found on CDC's website and FDA's website. So here's a snapshot of what the table now looks like. I do not have the headers on this slide, but I'll tell you that the left-hand column is the vaccine. The middle column is the vaccine itself, the temperature range, and the right-hand column is the diluent storage range. So that's what the three columns are. And I've mentioned that we now, for varicella-containing vaccines, varicella virus-containing vaccines, we have the lower cutoff now of negative 58 degrees Fahrenheit. We've updated our temperature logs as well, the figures in the back of the section. We have one for refrigerator storage, one for freezer storage. These are borrowed from the Immunization Action Coalition. We prefer separate units now, standalone units, so it makes sense to have separate logs, separate pieces of paper to tape to the refrigerator or whatever. They've been tweaked a bit so that it's harder for a provider to check a box off when the temperature is out of range and then ignore it after that, which emphasizes the need to take immediate action. Here is what the temperature log looks like for refrigerators. And you can see that there is, we have a row. It's kind of hard to see on the slide, I guess, but about 4 rows down, there's a specific row to log minimum, maximum temperatures over time. We now have a recommendation to record that twice a day. So that's now on this log. And we have, as mentioned, the acceptable temperatures for refrigerated vaccines with really a big red line at the bottom. You have gone too low, you need to do something. And here is the corresponding temperature log for freezers with the big purple line at the top. If your temperature gets too warm, you need to do something. So that's the new temperature logs. So that's basically it. I'll leave some time for discussion, and I'd like to thank the General Recommendations Work Group, liaison representatives, ACIP members, and consultants for their help in making these changes.
Thank you, Dr. Kroger. Open it up for any questions or comments. Hey, Dr. Rubin.
I just had a question about the multi-dose file. So I guess that's coming out of the general recs in favor of the other document. But the specific question was, at our hospital at least, when we enter a multi-dose file, after 30 days it expires. It doesn't matter what the expiration date on the file is. I don't know where that comes from, or if that's a general principle that clinicians use, or how that conflict is resolved in other places.
Right, so the issue is, it's kind of an inventory issue in reading the expiration date on the vial. That is something that is in the toolkit and is not in the general, will not be kind of mentioned in detail in the general recs anymore. The U.S. Pharmacopoeia, I believe, was one of the first organizations to really post a lot of this information about the 30-day open rule. There are certain vaccines for which the package insert states a longer period of time, multi-dose vaccines that need to be entered and reconstituted. The meninge polysaccharide vaccine was one of them. For the most part, most of the vaccines that are in use are single-dose vials that have that 30-day recommendation on it. So we don't feel that that's going to be too big of an issue, and the details will be in the storage and handling toolkit.
Question back here.
Dr. Christine Hahn from
Thank you,
CSTE.
Christine.
I had two questions. One is on the response to the temperature incident, or the out-of-range temperature. It says that it shouldn't be administered unless it's determined to be safe to do so. And I'm wondering if that should say safe and effective, because really the concern is more about loss of efficacy usually than a safety concern. And so I just made that comment.
I think that is definitely, that's definitely an addition that we can make. I'll make sure it doesn't gets too redundant with the language, because we do talk about that issue later, but that's definitely a change that can be made.
Okay, and then my second comment was on the table, and I know we're only seeing a portion of the table where you said the temperatures referred to the diluent temperatures, where we're just seeing part of the table for the varicella vaccines. And I wonder whether it could possibly be confusing to people, that third column for the diluent where there's prominent language about the temperature range, and I wonder if people might misinterpret that as being the vaccine temperature range, because it's in the same, whether it should be separated more clearly or something. I just thought, glancing at it, somebody could misinterpret that possibly.
Can we go back to the 14 is a good one. So this is a snapshot basically of the table. I guess we have the top header of the entire table, which contains all of the vaccines, will indicate what these columns stand for. Whether we can do some formatting, we'll look into that, but we'll be clear that this information is the diluent and the other information is the vaccine.
Ms. Hayes?
To address Dr. Rubin's concern, this is Carol Hayes with the American Nurses Association. I'm fairly certain that it's a Joint Commission requirement in a hospital that you have to discard something after 28 days. And I feel like in the outpatient setting, that probably doesn't apply.
Thank you for that comment.
I'm not sure if you're the best person to respond, Andrew, or if it should go to Dr. Moore. But just a general question in terms of both VFC sites and non-VFC sites. And I'm thinking of the thousands of clinics across the country that house vaccines. What type of ongoing training and scrutiny do these sites get? I think oftentimes the vaccine is a huge amount of their throughput cost. But I'm curious, how do we translate the recommendations into action?
Sure. Kelly Moore with AIM. So immunization programs work with the VFC providers very carefully. We have extensive training conducted using CDC materials, and we are extremely appreciative of the new materials that have come out, the more detailed toolkit that finally gives us a lot of detailed specific information. We've got online modules that people can do on their own, and requirements for all of our VFC providers to undergo education and storage and handling annually that have just now started to kick in. So we do site visits at least every other year, if not more often, with them, and focus a lot on storage and handling. Once you're outside the VFC program, however, there is no involvement directly of programs in supervision of those who are involved in immunizing people who are outside the VFC program. But there are tools now available for them to go on their own to access through the CDC website, like You Call the Shots or EasyIZ, which is produced by California. So there are resources available, but it's up to them to seek those out.
And as a follow-up, do we have any idea of the percentage of sites that are VFC versus non-VFC?
Well, among pediatric practices, I don't have specific numbers, and perhaps someone from CDC would, but most pediatric practices participate in VFC, a good number of family physicians. But outside of that, when you get into the adult arena, pharmacies, adult providers, then that wouldn't be really a big player.
Thank you. Dr. Shukat.
Yeah, I mean, the VFC, most VFC providers are also providing vaccines to publicly insured people, and there are over 40,000 VFC provider sites. We've also made efforts to make it clear that pharmacies can be VFC providers if they do the, follow the requirements. So we've tried to expand it, but strictly, we're not doing site visits to the adult-only providers. There are other oversight groups potentially, but not us.
Thank you. And I think as an additional follow-up, maybe to Dr. Foster, my impression is because pharmacies are used to maintaining inventory at appropriate temperatures and so on, that's not as much of a concern in my mind as it would be in the private adult practice that has some inventory but doesn't participate in VFC.
Steve Foster, American Pharmacists Association. We do watch storage and handling quite carefully. We don't. I would say that on the average, though, not sure that 100%. I know not 100% is totally compliant with all of the rules of the toolkit. Things like the separate refrigerator, freezers, and those types of issues. It has been distributed to the pharmacists out there, but still, this is more of a corporate decision in many of the places what they do. But they have not really been enforced on that. But so some are doing it, some are not. I guess is the best way I can say that. But as far as regular storage, I mean, they do have other medications, so it is monitored. Ones that they do have monitored quite well is a requirement.
Any other questions, discussion? Okay. Oh, Dr. Shugat.
Just making an additional comment that, a couple years ago, the Office of Inspector General reviewed the storage and handling in the Vaccines for Children program and found a number of concerns. We issued a corrective action plan, and much of the training and toolkit that you are hearing about is a result of that response. I'm told that there's been a huge uptick in accessing the toolkit and the training, not just, through what we're pushing, but additional ones. So I think that the work that the programs, both at CDC and the states, have been doing is showing up in use of the training materials.
Thank you.